new but relatively topical GLP-1 receptor agonists and NAION, as well as other ocular effects. And so I'm going to present a case known to another ophthalmologist, which had some very interesting optic nerve features in association with Ozempic use. This is Mr. DP. He's a 53-year-old gentleman who presented with some clouding of his vision that had occurred over the previous 3 to 4 weeks. On his initial presentation, his visual acuity was actually very good, 6.6 bilaterally. His intraocular pressure was normal. He had normal pupil reactions and no RAPD. He had full color vision and his ocular media was clear and his retinal examination was normal. Now, his past medical history, he had hypertension, he has dyslipidemia and type 2 diabetes, which he's managed with a number of anti-diabetic agents, including Ozempic, which he had recently increased the dose within the last 6 months. Now, the most pertinent finding on his examination was his optic nerve features. As we can see here, this is the picture taken of his right fundus on that initial presentation. And he had bilaterally swollen optic nerves, right being worse than the left, and we'll focus on the right eye throughout. He's got a little bit of retinal nerve fiber layer hemorrhage in that side as well. And his OCT confirmed right greater than left optic disc swelling. I'll just keep going. And so his visual field showed some scattered loss in both eyes, but a reasonably significant inferior arcuate scotoma in the right eye. And we're going to track that through his multiple presentations. So differentials for bilateral optic disc swelling include optic neuritis, papilledema, and to an extent NAION. He underwent an MRI for which didn't show any cause for his bilateral optic disc swelling. Importantly, no evidence of intracranial lesions and raised intracranial pressure. So it was decided he would cease his Ozempic and be followed up in 1 month's time. And so these images, the first one on the left is from his initial presentation, and the one on the right here is from his subsequent follow-up at 1 month. And we can see there is still, well, there's a new temporal disc hemorrhage, but importantly, his degree of optic disc on these BMO analysis scans, we can see the difference in his initial scan from first presentation and the follow-up on the bottom of the screen there, with improvement in his optic disc swelling. And this was mirrored on the left side also, just not as nicely shown as in the right side here. His perimetry also improved. Those first 2 columns are both from his initial visit, with the third column there from his follow-up at 1 month, showing some improvement in that inferior arcuate scotoma as well. He was then followed up another month down the track, so 2 months following his initial presentation. And on the left is his initial scan, right is that follow-up scan from 2 months down the track, demonstrating very nice improvement of his optic disc swelling in the right eye. And so the topic of today is NAION and optic nerve changes. So just a brief introduction. I'm going to let my colleague do the remainder of the discussion on NAION, but in terms of the pathophysiology, it's not entirely well known what causes it. The theory is that there is some sort of ischemic event contributing to it and causing issues at the optic nerve. There's a number of risk factors, including small optic discs, as well as vascular risk factors and other coagulopathies that can contribute. Presentation, there is vision loss to some extent usually, not as significant as the arteritic form. There can be color loss as well, although this may be maintained depending on the severity and the duration of the insults. It's typically natural deficits on presentation, and usually there is some optic nerve head edema and can and have to rule out papilledema or raised intracranial pressure, as well as optic neuritis. Now, the interesting component of this case was this gentleman's Ozempic use and the improvement in the appearance of his nerves following cessation of it. So GLP-1 receptor agonist, and these have become commonplace in the treatment of diabetes as well as for weight management. And I'll quickly go through their mechanism of action and then some of the associated ocular effects that have been discussed. So they bind the GLP-1 receptor, as the name suggests, and they stimulate insulin secretion at a glucose-dependent rate, which is aimed to mimic healthy individuals' release of insulin. They also lower glucagon secretion in concordance with the degree of glucose, and also they slightly delay gastric emptying. Those second two also contribute to increased satiety and a decreased appetite, which assist with the weight management. In terms of adverse effects, they have a host of systemic adverse effects, but in terms of the eye, they have been demonstrated to cause progression of diabetic retinopathy, and particularly so in those patients that already have a baseline retinopathy. And it's thought to be in relation to the rapid tightening of glucose control, which is a similar premise and mechanism that's sometimes seen in pregnant patients that have pre-gestational diabetes and diabetic retinopathy that see acute worsening during their pregnancy because of, or thought to be because of the tight control of glucose during that time. And so the relation with NAION crept up due to this report by Hathaway and colleagues in 2024. They looked at a single centre's presentations of NAION and developed these cohorts of diabetics and people being managed for weight loss, and identified a number of cases with semaglutide exposure. So semaglutide is one example of a GLP-1 receptor agonist. And they demonstrated quite a reasonable risk association or hazard ratio for NAION in conjunction with exposure to semaglutide at 36 months. Now, there's a number of limitations with this study, as well as some of the others we'll look at, which typically revolve around their management of confounding factors within a population. And of course, these are all association-based studies. Demonstrating causality is particularly difficult when looking at interactions at this level. Regardless, this study was followed up by a number of others more recently that have similar methodology. So Chu et al. In 2025 used a multi-institute approach and access electronic medical records and diagnostic codes to identify quite a number of participants. However, they found no statistically significant increase in the rate of NAION in patients on these GLP-1 receptor agonists. Similarly, they had issues with their confounder management, as did the initial study, and it also looked at Caucasian patients. Su and colleagues had an even larger study, and conversely, they did find an increased risk for NAION at the 2, 3, and 4 year mark following initiation. They didn't find any increased risk of NAION at the 1, 3, and 6 month points, interestingly. And Abbas and colleagues, again on a very large cohort, looked at semaglutide and other GLP-1 receptor agonists in populations for diabetes and weight management, and they found no increased risk. So what we're seeing is a number of big studies looking at an association level risk analysis between NAION and GLP-1 receptor agonists. So finally, this has been followed up most recently by this study by Lakhani and colleagues that has just recently been published by AJO. They've utilized a relatively large database, including the US FDA Adverse Events Reporting System and the WHO Vigi-based system, both of which are designed to allow clinicians to report adverse events associated with medications. And they've looked for a variety of associations, including optic nerve issues and retinal adverse events in patients that have been treated with semaglutide in particular. They established an increased risk for NAION as well as diabetic retinopathy progression in both cohorts. And interestingly, they found some other associations, including retinal detachment, as well as macular edema, macular hole, and papilledema in conjunction with the use of NAION. Again, establishing causality is a significant issue for these studies, but they did show, in comparison with exenatide, which is another GLP-1 receptor agonist, this didn't have as many or as high a risk association as semaglutide did. So they hypothesized that possibly there's a more specific drug-related interaction between the different GLP-1 receptor agonists than just the group as a whole. And if anyone's interested, there's a nice review of that article on a review of optometry at that link below. So is there any established mechanism for how these drugs may be increasing the risk of NAION? Unfortunately, we don't really have a good idea of the mechanism behind NAION in and of itself, so that doesn't help. There's some thoughts that potentially at the receptor level, changes to the microvascular environment at the optic nerve could be contributing to hypotensive episodes, which is a prevailing theory for NAION at the moment. Similarly, the rapid improvement in glycemic control that lots of patients see with GLP-1 receptor agonists might be a contributing factor, but really, I think it's anyone's guess at the moment exactly whether there's an interaction and how it does work. And so in conclusion, there's, I'd say, an unclear link between NAION and GLP-1 receptor agonists. However, given there's been such a massive uptake in these medications, and us as clinicians are becoming more and more likely to see patients on them, and the associated risk factors that are already established for NAION, I think it's reasonable to consider these drugs as potentially reversible risk factors for NAION, as we have potentially seen in this initial case presentation. These are the citations, and thank you very much.
Thanks very much, James. That was a really very interesting case, and interesting how it was picked up quite early, really, and how the visual fields in particular improved following cessation of the...
And the bilateral aspect of it, I think, is interesting as well. The left nerve certainly looked like a small nerve and one potentially at risk. And so interesting to see such a quick change with the cessation of Ozempic.
Yeah. We'll hold questions till the end. We have Dr. Cynthia Nusanti, who's an expert in neuro-ophthalmology. Cynthia, we'd love to hear your presentation, if you don't mind. That would be terrific.
Okay, Prof. So we will discuss this case after my presentation. Is it okay? Or we can discuss...
Or unless you want any... Do you want to ask a question now?
Yeah. Maybe I want to ask questions whether, Dr. James, do you make a differential diagnosis of papillopathy diabetic on these patients? Because the non-arthritic ischemic optic neuropathy is rarely bilateral, even though right now we still don't know the relationship between the Ozempic with the semaglutide with the NAION. But in patients with the type 2 diabetes, if the both optic nerve is edema, maybe the first of our diagnosis will be the papillopathy diabetic, even though these patients have the arcuate visual field defect. May I ask, how about the glucose on these patients after the cessations of the semaglutide?
Yeah, I don't think it's an unreasonable differential, certainly to have for bilateral optic disc quelling in a diabetic. I think for them, they didn't really have a significant degree of diabetic retinopathy. I'm not sure about their overall diabetic control, but certainly a reasonable consideration and worth looking into their glucose control. But just given their improvement coming off one of their diabetic medications, I think it's reasonable to think that it's probably unrelated to the diabetes in that context. I don't know how you feel about that, Prof.
Yeah, this patient was actually a patient of mine. Their blood sugar control was reasonable throughout, actually. It wasn't blood sugar, I can't remember the actual figures, but it wasn't terribly high. And you're right, it's unusual to have a bilateral non-arteritic ischemic optic neuropathy. And so one of the differentials would be a papillitis, like a diabetic papillitis. But then when I thought about the pathophysiology, both conditions really result from microvascular changes at the level of the optic nerve head. So in a way, it's potentially a similar pathophysiology, but just manifesting slightly differently. And I thought it was reasonable, given the case reports of Ozempic causing an NAION picture, to stop. It was the only treatable thing we could do. In the old days, when I was at James's level as a registrar, we would sometimes, this is a long time ago, James, we would sometimes put those patients on systemic steroids. But of course, him being diabetic, I was not going to do that. So I thought the only really treatable option I had was to stop a factor which I thought could be implicated, and that was stopping the Ozempic. And it's probably a bit of luck, but fortunately his feels and clinical features have improved. But it's a great question. But I'm not sure what you think about the pathophysiology, but I think if in effect diabetic papillitis and NAION sort of merge a bit, because the underlying causation is almost certainly microvascular occlusion from, well, theoretically from various mechanisms.
Yes, Prof. So usually the diabetic papillopathy also happen in patients without the backgrounds of retinopathy, right, Prof? So usually the retina is clear and the patients come with only the optic nerve. So it's a little bit difficult to differentiate between these two, but because of the patients have bilaterally, we also have to think of in our mind that maybe this is also because of the diabetic, because up until now we cannot find any exact mechanisms of the GLP-1, except that the GLP-1 said that can be reduce the systemic blood flow, so it can reduce the blood pressures. So that's the one that also one of the pathogenesis of the suspected pathogenesis of the non-arteritic ischemic optic neuropathy. So maybe we can look up these patients again. So it's 1 month only, Prof, for the follow-up, or it's
No,
already several months?
I saw him recently. It started in, I think, February. I saw him in June, so it's 4 months, and it's continued. He's leveled off now, basically.
Is it the optic nerve still have a edema look, or it's
He
already
had, yeah, if I recall, he had a small hemorrhage, but the swelling has reduced. Yeah.
Yeah. Usually the non-arteritic will be already atrophic in the 6 weeks. So maybe we can learn much of these patients, Prof, after the 6 months.
Well,
Okay.
yeah, we'll keep seeing him.
Okay. Can I move with the presentation, Prof?
Yes, please. We'd love to hear from you, Cynthia. Thank you very much.
Thank you. Let me try to wait. So, thank you, Prof. Morgan, for the introductions, and good evening, everyone. Tonight we'll be discussing the non-arteritic ischemic optic neuropathy. The challenging diagnosis in neuro-ophthalmology is not because of the diagnosis itself, but because it's always unfavorable outcomes for our patients. And hopefully after tonight discussions, we will gain understanding of the disease and explore ways to improve our management. I'm sorry, Prof. My internet is not very good, so I think I will close my video and we'll be starting with the, sorry.
We can see your slide. We can see your slides quite well, actually.
Yes,
No, it's
yes, but there's information for me that the internet is not very good. But so I prefer to close the video so I can share the screen very. Oh. So we will begin with the case. It's a woman 51 years old with presented with blurred visions in her right eye since 2 months ago, and which she first noticed this upon awakening. She also reported headaches, but denied any other significant symptoms, and there was no history of systemic illness or underlying medical conditions. Previously, she had been treated by an ophthalmologist in the with steroid for 1 month, but other history of hypercholesterolemia and history of hypertension. From ophthalmological status, we found that the visual acuity is and movement on the right eye, and 6/6 on the left eye. We found RPD and the other within normal limit. Because no significant improvement of visual acuity, the patient then sent to our hospitals. This is the fundus photograph in our hospital. So we can see here that is optic atrophy on the right eye. This is the picture from the patients that we can see on the right eye. Sorry, the picture is not very good because I'm taking it from the phone of the patients. There's an edema on the right optic nerve. So we did the OCT of retinal nerve layer. There is a thinning on the superior and inferior, and also the loss of the ganglion cell. And right now we're using the OCTA prof in the patients with non-arthritic ischemic optic neuropathy, and we found that also a blue area is in the superior and also in the inferior. So these patients, we diagnose with these patients with non-arthritic ischemic optic neuropathy and deal with the risk factors. So, by definitions, the ischemic optic neuropathy is optic nerve disease resulted from transient or permanent interruptions of the blood supply to any portions of the optic nerve. And by classification, if we can see based on the locations, it divided into the anterior and the posterior. And from the etiology, it divided into arthritic and non-arthritic. So ischemic infection of the retrolaminar optic nerve with variable involvement of laminar and perilaminar regions characterize both arthritic and non-arthritic anterior ischemic optic neuropathy. The anterior ischemic optic neuropathy is most common acute optic neuropathy in patients older than 50 years. Usually come with the painless monocular vision loss that develops over hours to days. And the optic nerve head edema will be present at onset preceding the visual loss. So this is the difference between the arthritic features and the non-arthritic. The arthritic anterior ischemic optic neuropathy typically affects older patients with a mean age of 70 years and is more common in females, and is often associated with systemic symptoms such as headache, scalp tenderness, jaw claudications, and transient visual loss. In contrast, in non-arthritic features, the occurs slightly in younger one, around 60 years, but in our patients, the youngest patients in our hospital is 35. And it is usually not associated with any systemic symptom. Regarding the visual acuity, the arthritic ION tends to cause more severe vision loss, with over 60% of case having visual acuity worse than 20 to 200. But in NION, the visual acuity tends to be better. We still have patients with 6/6, but have a visual field defects. And funduscopy, the arteritic anterior ischemic optic neuropathy usually show pallid edema and often with Cuttle-Wand spot or even choroidal ischemia. But in the NION, usually the hyperemia come in the segmental area. From the laboratory, we can see that the C-reactive protein, the erythrocyte sedimentation rate will be elevated, while in the non-arteritic, usually normal. And the natural history from the arteritic feature rarely improve, and untreated fellow eye will be involved within 1 to 2 weeks. In non-arteritic, fellow eye will be involved in 50% in 5 years. We also have to differentiate between the NION and also the optic neuritis. Usually the onset will be younger in the optic neuritis, even though we have the patients over 50 also. And the visual field defect will be altitudinal or acute in non-arteritic ischemic optic neuropathy, and usually in the optic neuritis will be central. Usually in non-arteritic will be 100% edema, even though it's a segmental edema. But in the optic neuritis, usually some of them will become with normal fundus. And retinal hemorrhage is common in NION, but the optic neuritis is unusual. And if you do imaging, you will find no optic nerve enhancement in non-arteritic ischemic optic neuropathy compared to optic neuritis. Non-arteritic anterior ischemic optic neuropathy is 90 to 95% of case of anterior ischemic optic neuropathy, and occurs in relatively younger patients compared to the arteritic one. The annual incidence is 3.6 to 10.2 per 100,000 people, and usually is we can find the clouding of the optic nerve head in the contralateral eye, and typically is not associated with any systemic symptoms. And although the exact mechanism is still unclear, like James said, it is suspected that the NIONs occur to the insufficiency of the posterior ciliary artery circulation that can cause the ischemia of the optic nerve head. If you remember, the optic nerve head contains a watershed zone, an area between two arterial supplies that is particularly vulnerable to ischemia when perfusion will be dropped. In a study of 100 subjects, no two were exactly alike, even between the two eyes of the same individual. So this region is most susceptible to ischemia when there is a reduction in perfusion pressure of the posterior ciliary artery and its branches. So the most important thing of non-arteritic ischemic optic neuropathy is the risk factor, because this is the one that we can modify. 60% of patients with NION have systemic vascular risk factor. The first one will be the structural crowding of the optic nerve, this at risk, the diabetes mellitus, the systemic hypertension, hyperlipidemia, and obstructive sleep apnea. But still, some of the risk factor is still controversy, like hypercoagulable disorder, nocturnal hypertension, and some of the drug, the PDA5 inhibitor, amiodarone, and semaglutide. We have a 5-year data in our hospital. The study is on 2012 to 2017. The most common risk factors in 2012 to 2017 is hypertension. But while we doing another research in 2020 to 2023, our patient have a 100% dyslipidemia of the non-arteritic ischemic optic neuropathy. So, and most of these patients have 2 to 3 systemic risk factors. And a study by Kochak et al. Reveal a relationship between the atherogenic indices in non-arteritic ischemic optic neuropathy, which have been previously used this biomarker for cardiovascular disease. So the study found that the NION patients have significantly higher atherogenic index compared to controls, and this index may be useful to predicting severe vision loss and second eye involvement and managing lipid profiles right now, because we found that 100% of our patients is dyslipidemia patients, maybe help to reduce the progression risk of the NION. Right now we have another study, but the result is not coming yet for the atherogenic index in our patients. So, recent study have also show a significant association between the metabolic syndrome and its component to non-arthritic anterior ischemic optic neuropathy. So, if we can see here, patients with METs were more likely to have an optic neuropathy than those without the metabolic syndrome. And also, additional research support the strong link between the obstructive sleep apnea and NION. So if you have patients suspected with NION, so you have to ask the patients several questions regarding the obstructive sleep apnea. So as we know, maybe all you know, that PDA5 inhibitors have been used too extensively for the erectile dysfunctions and have been suggested have a potential cause effect relationship between the use of this drug with the onset of non-arthritic ischemic optic neuropathy. And if we have patients with NION, the use of the PDA5 inhibitor is contraindicated because it may be caused another NION in the contralateral eye. And this is the one that James talked about before, the risk of non-arthritic anterior ischemic optic neuropathy in patient prescribed semaglutide. Even though that we don't really know the relationship between these two, but this is a rise question because the use of the semaglutide right now is very large. So this study is comparing the risk of NION in patients with type 2 diabetes and those with or those who are overweight treated with semaglutide versus those receiving non-semaglutide. So they're primarily associated with the higher risk of NION. And also another research, the semaglutide and non-arthritic anterior ischemic optic neuropathy said that the risk of NION among semaglutide user was not significantly different compared to the use of another GLP or receptor medications, but they have a higher only compared with patients taking empagliflozin. I think James already mentions about this paper. But the GLP-1 affect vascular dynamic via the autonomic nervous system and lower systemic blood pressure. This is the one that we suspect also the pathogenesis of the NION. We also try to evaluate the relationship between the hypercoagulable manifestations in patients with the NION. We found that there is an elevated of endothelial selectin and beta-selectin level in patients with non-arthritic ischemic optic neuropathy. So maybe this one can be the reason that we can give the hypercoagulable therapy on those patients. There's a multiple systems of the patients with non-arthritic ischemic optic neuropathy, such as dyslipidemia, diabetes, hypertension, obesity, and smoking, and also obstructive sleep apnea that contribute to the NION. So while hypercoagulability and snoring have shown weaker associations with NION compared to other. We also have a study that try to correlate the risk factor of accelerated finding and clinical characteristic in NION with the risk factor. We found that from the OCT, the GCAPL thinning is significantly associated with the history of snoring, and also the retinal nerve fiber layer thinning is significantly correlated with dyslipidemia. We try to propose algorithm for the NION management in our hospital. If patients presenting with sudden blurred vision or vision loss will be undergo visual acuity, funduscopy, visual field examination, supporting tests such as OCT of retinal fiber layer, OCT of ganglion cell, and OCTA to assess the nerve fiber thickness, ganglion cell damage, and blood flow. And we also assess the systemic risk factor evaluated for dyslipidemia, hypertension, diabetes, obesity, smoking history, and sleep apnea. If the patient has 3 or more risk factors, we proceed with the coagulations test. If fewer than 3, we recommended routine follow-up and schedule on 1 month or 6 months. We try to do a proposed mechanism for the NION. This slide shows how NION will develop ischemia of the optic nerve, head levels to axonal swelling, and worsening ischemia and ganglion cell damage. And over time, this result will be giving the atrophy in the hypercoagulable patients, and the OCTA will show more perfusion loss with greater thinning of the retinal fiber layer and ganglion cell, in worse visual field defects in patients with hypercoagulable. So we come to the NION itself. The NION is thought to be a compartment syndrome, and where the infection occurs within the scleral canal alone. Most cases are static, vision loss will be stable from onset, but some will be progressive with the episodic and decrement of the visual acuity. It occurs approximately in 12% of NION cases. So from the ophthalmological status will be vision loss usually less severe, but you will find the visual field defect. Visual acuity and color vision might be normal if fixation is spare, but RAPD is present. The optic nerve edema may be diffuse or segmental, and it's usually initially hyperemic. The contralateral eye will be typically small with absence of physiological cup, and we call it dysatresis. And within 6 to 8 weeks of onset, the optic nerve will be usually become atrophic. Initially, we see the optic disc will be edema, visual acuity decrease, and 6 to 8 weeks, the atrophy will begin in the segmental area. This is the visual field defect correlations with the atrophy of the optic nerve. The will be the correlated visual field defects. So from the fundus will be demonstrate superior segmental optic nerve head swelling in the right eye of the patient with NION, and the left eye will be this usually demonstrate the small cup to this ratio. So if you want to try to differentiate between the non-arteritic and arteritic, the picture A is the healthy eye with the correcting disc. The B is the NION, the edema is segmental, and the C is the healthy eye demonstrate normal cup disc ratio, and the D is the patients with the arteritic anterior ischemic optic neuropathy. So in the patients with arteritic anterior ischemic optic neuropathy, the pallor is more pronounced compared to the non-arteritic one. Sorry. So in this picture, we found there's some of the macular edema presence in the patients with non-arteritic ischemic optic neuropathy. Usually we found this edema in patients also with the diabetes. So we try to look upon our patients. There is a macular edema in some of our patients with non-arteritic ischemic optic neuropathy, usually with the one with the diabetes mellitus. Some of these examination can be used to not only try to differentiate the edema of the optic nerve from the ischemic optic neuropathy, but also for the follow-up of the patients. Right now, we're using the OCTA to evaluate the blood flow in the peripapillary area. We see the capillary perfusions and also the flux index. This case report is highlighted the role of the OCTA in NION follow-up. At 1.1, we can observe that the persistence of optic disc changes, visual field defect, and reduced perfusion at the OCTA, and also the retinal fiber layer and GCAPL thickness measurements show ongoing structural damage. So I think this patient have not the static one, but the one that continue to regress in the optic nerve. We also try to see the spatial correspondence of visual field defect with OCTA results of the non-arteritic. If we can see here, if the OCTA is on the superior, so the visual defect will be in the inferior. So what next? What is the management of the non-arteritic ischemic optic neuropathy? So for us as a neuro-ophthalmologist, NION is still remain a significant challenge. So management of the NION is focusing on the reducing of the edema, restoring perfusion, and protecting the neurons. Steroids and anti-VEGFs, they said that can help resolve this edema, but up until now, the results of the several study is not very good. So some of the studies said the decompression may help prevent worsenings of the vision. Vasodilator and antithrombotic also can give secondary preventions of the contralateral eye involvement, and said the steroid reduce the capillary permeability and accelerate resolutions of edema. We can see after this we can try to see one by one the treatment that can be given to the patients with NION. Why giving steroid? They said that the steroid can be reductions of vascular permeability, reductions of edema, cell membrane stabilization, can give neuroprotection, and increase the retinal ganglion cell survival or optic nerve functions. So the reason to give steroid of these patients with NION is several studies said that 60 milligram oral steroid can improve the visual acuity. And still, the visual, some of the study done by Harris said the steroid therapy within the onset of 2 weeks can give the optic disc edema resolutions 6 to 8 weeks compared to 8 to 2 weeks patients without the steroid. They conclude that NION treated during acute phase with steroid systemic gives significantly higher probability of improvement in visual acuity and visual field compared to untreated one. But some of the study also giving the reasons not to give steroid. Steroid do not improve the outcome of patients with ischemia. And spontaneous resolutions of optic disc edema from onset of visual loss is not given any visual acuity improvement. So high risk of high-dose steroid therapy because of systemic disease and age. As we know that patients with the non-arteritic ischemic optic neuropathy usually have several risk factors. And no randomized clinical trial been done up until now to use the steroid in patients with non-arteritic ischemic optic neuropathy. There is a meta-analysis of the steroid in the treatments of non-arteritic anterior ischemic optic neuropathy. So the conclusions of this meta-analysis is steroid do not significantly enhance visual outcome in NION, and given their lack efficacy and potential side effects, steroids are not recommended for reversing ischemia in NION. So when you can give the steroid, sometimes this is from one literature, but I also use this standard proceeding to give steroid to my patients. If visual acuity is worsened than 6/30, the patient comes in 2 weeks of onset. No significant risk factor for steroid-related side effects, such as infections, severe diabetes, severe hypertension, and peptic ulcer. Or the patients come with the incipient non-arteritic ischemic optic neuropathy, the edema with the good visual acuity, only the visual field defect, usually in the inferior, Our patients come with monocular visions, or the patients come with bilateral simultaneous non-arthritic ischemic optic neuropathy. But also we have to have collaborations with the internal medicine, given the patients with the non-arthritic ischemic optic neuropathy have a risk factor, systemic risk factor. But another review is about the neuroprotective strategy. Because we cannot do anything with the optic nerve, we try to find is there anything that we can give that will be restore the ganglion cell or the retinal nerve fiber layer. So some of the literature some of the research try to find the neuroprotective strategy for non-arthritic. Sorry. So neuroprotective strategies so promising, especially in animal model, in preserving the retinal ganglion cell and preventing the apoptosis. Even though the human data is limited, but it's still also encouraging. And further clinical study are needed to confirm the efficacy, safety, and impact of the visual functions of the patient with NION. Usually we use the citicoline here in Indonesia to give the patients with the NION, and also we try to find whether the citicoline have a good result in the visual field effect. Usually the patient feel that the defect will be become more grayish compared to black after using the neuroprotector. So, but we don't have any randomized clinical trial for this using of the citicoline. And also, right now, we try to give the treatments of the hypercoagulable if the patients have the hypercoagulable states. And we found in the several cases, it can give the good benefit on the visual acuity and also the visual field. So what's next? What's other research in NION? Some of the study try to give another pharmacotherapy, another neuroprotection, but all still have no significant results in the patients of the NION. But we hope we can get more of these results on the research. Can we give stem cells on these patients? Some of the stem cells are some of the research are tried to give the stem cells in the patients with ischemic optic neuropathy. Some of the case reports said the visual acuity was improved, but there is no randomized control trial on this using of the stem cell. Not to forget, there's a quality of life and associations with these patients of non-arthritic ischemic optic neuropathy. So in every patient with optic neuropathy, we should ask the patients their quality of life and what we can do with these patients. How about the prognosis? 5-year risk of contralateral involvement will be happen in 50 to 24% patients. It will be manifest as pseudofaster Kennedy syndrome. And from the ischemic optic neuropathy decompression trial, 43% of patients with visual acuity less than 20 to 64 at presentation regain at least 3 lines of the Snellen eye chart within 6 months. And risk of recurrence in the same eye is estimated around 3 to 8%. So maybe from the take-home message, the prompt recognition and medical intervention are essential to prevent further damage and vision impairment. The one that we can do is managing this factor and can help reduce the risk of developing an NION in other eye. Please talk to your patients. Explain well that what we can do right now is managing the risk factor. And don't let the patients run, because maybe in 1 year they will come again to you with the contralateral eye involvement. There are currently no definitive treatments to resolve vision loss in ischemic optic neuropathy, especially in non-arthritic cases. So we have to prevent risk factor are the main focus. And there's a lot of ongoing promising research. We hope there is always light in the end of the tunnel of these patients. Thank you for your attention. Hopefully it can help to manage our patients. Thank you, Prof.
Thank you very much, Cindy. That was a fantastic summary of quite a complex area. Now I'm just going to check. We usually have some questions on the chat. So we have a question from Michael Hartono. Thank you very much for the presentation, Dr. Cindy and Dr. James. I'm Michael from Australian-Indonesian. In a diabetic patient on Ozempic or semaglutide who presents with painless vision loss, how can we clinically and with OCT differentiate possible semaglutide-related optic neuropathy from NAION, toxic optic neuropathy, or diabetic papillopathy? Are there any reported OCT patterns that help distinguish? Cynthia, I think you're the expert here. I'd love to know.
Yes, actually, Prof, I don't have much experience with patients with Ozempic. I don't have the patients like you, but I think the answer will be there is no patterns of the OCT of the patients with Ozempic. We can only say if the patients have the pattern of the OCT or the visual field defect for like patients with non-arthritic ischemic optic neuropathy. So we suspected these patients with Ozempic have the NION. But in patients with suspected of diabetic papillopathy, the patterns of the OCT will be different, and also for the OCTA. And I don't have any experience with toxic optic neuropathy in patients with semaglutide, but I think because it's also related with the systemic risk factor, I think it will be related to the what kind of ischemic optic or what kind of the optic neuropathy happen in these patients with the Ozempic. I think that's the my answer, Prof.
Yeah, it's an interesting question. Have you seen a difference between diabetic papillitis and NAION on either standard OCT or OCT angiography? Have you seen a difference in the pattern of the OCT findings?
Yes, Prof. Usually in patients with NION, because the visual field defect is superior or inferior, so the OCT of the retinal nerve layer and OCT of the ganglion cell will be also the same. It's in superior defect or inferior defect. Also in OCTA, some of our study found that if the OCTA, the capillary perfusions, and also the flux index will be lower in the area of the atrophic one. So if the patients are already atrophic and we try to find the OCT pattern and OCTA pattern, we will be found the exact same area of the visual field defect. So superior will be the OCTA will be in, if the defect is inferior, the OCTA defect will be in the superior, also the ganglion cell. But in patients with diabetic papillopathy, because it's already around, it's not segmentally. So sometimes in the 6 months, the retinal nerve fibrillary is still edema. So like I said before, in James' cases, in non-arthritic ischemic optic neuropathy, usually 6 to 8 weeks, the area of the optic nerve will become atrophic, not edema all the time. So it's a very interesting case in James. So we can try to find when is the edema resolved.
So in fact, our case might be a sort of diabetic papillitis if the edema persists. Yeah.
Yes.
Thank you. We have a question from Tiara Azrina. No, Tiara is asking you to deliver questions. Wait a minute, there should be more. Yeah, sorry. We haven't got any other questions on chat, but I've got a question regarding, so you covered a lot of ground, Cynthia, and it was a really interesting talk. Are you finding OCT angiography useful in terms of diagnosing NAION. And does that help in any way to differentiate from optic neuritis or, say, standard papilledema in your experience?
Thank you for your question, Prof. Yes, right now, if we are, because our hospital is a tertiary hospital, usually we get consultations on the patients is already been taken care of in other hospital. So it will become late to our hospital. So we have to really, really differentiate in the beginning whether we are going to diagnose these patients with the non-arthritic or with the neuritis optic neuritis. So we usually examine the OCTA, Prof. In patients with non-arthritic ischemic optic neuropathy, will be see the blue area larger compared to the patients with the optic neuritis. Even though um, patients with the longer optic neuritis will also have uh, the capillary perfusion decrease compared to other. But in patients with non-arthritic ischemic optic neuropathy, it occurs usually around 2 to 4 weeks after the incidence. Because in the before 2 weeks, the optic nerve is still edema, so it's rather difficult to get the examinations of the OCTA. Still, usually we cannot get very good pictures of the OCTA because if you can, what I can say that there's still an area of edema. So usually we can get no clear image of the capillary perfusion and flux index. But in patients already on 3-4 weeks, we can see that in the OCTA will be the larger area of the blue and the capillary perfusions and the flux index will be decreased. We found that the means of the capillary perfusions in normal patients or patients with also the contralateral eye of the non-arthritic patients is around 40 to 45%. So below the 40%, we can see the blue area will be larger compared to the other segment, Prof. So right now we use the OCTA to differentiate the non-arthritic and the optic neuritis, even though we are also use the other examinations.
I'm waiting for other people to ask questions, and while I'm waiting, I'll ask one more. Color vision, how helpful do you find the Ishihara, say, for diagnosing NAION, particularly, say, compared to optic neuritis or other optic neuropathies? And a second part to the question is, do you always use the Ishihara or do you use other color vision tests sometimes?
On the optic neuropathy, usually we use the Ishihara, Prof. In the patients with the ischemic optic neuropathy or optic neuritis, we use the Ishihara not to diagnose whether these patients have the red, green, or yellow, but we usually use it to compare how much plate that the patient can read. But in the patients with the toxic optic neuropathy, we usually use the Van Mansell because the Van Mansell is already proven to be useful in patients with toxic optic neuropathy. But in non-arthritic ischemic optic neuropathy, I'm not usually using any color visions to help me to diagnose the non-arthritic. Usually, I use the Ishihara for patients with optic neuritis to see whether the results of the treatment, Prof. Usually, we set this one plate from 20, and then the follow-up will be 5 plate to from 20, and so on. But I'm not using the Ishihara for the NION patients, Prof.
Well, thank you, Cynthia, and thank you, James, for really excellent presentations on quite a complex area. And I think all of us dread patients coming in with slightly swollen optic nerve, drop in visual acuity, and some visual field change. and your heart starts to sink because often you feel like there's not a lot you can do. But you've helped to clarify that for us, Cynthia, especially with the flow chart, with the treatment algorithms and the discussion of the treatment options. Well, I think, yeah, so I just want to thank everyone, and I don't see any other questions that have come through. Cynthia, thank you, and James. And Tiara, are we going to have photographs tonight? I'll hand over to you if that's okay.
Okay, thank you, Prof. Good evening, everyone. Thank you for joining today's lecture. I kindly ask everyone to turn on their cameras as we will be having a photo session. Okay, I will now begin the photo session. Please give us your best smile. 1, 2, 3. Okay, next page. 1, 2, 3. Okay, that will be all. Prof. Morgan, back to Prof. Morgan.
Well, thank you very much, Tiara. And thank you everyone for coming. I look forward to seeing you all next month. We'll have another great session. Thank you. Have a good evening, the rest of your evening. And I'll see you, everyone. Bye. Bye.
Thank you, Prof. Thank you, Prof. Thank you. Thank you, James. See you next month.
May tanong iya.